Hey guys! Sorry it took me a little while to get here. I couldn't remember how I did it last time, so I don't know if I did it on my computer or my phone, but I'm on my phone today and I can't figure out where to look. So sorry about that. Hopefully I'm live. If you are watching, please go ahead and just type something in the comments. I'm on my own page over here trying to see if I'm live, and I'm not seeing anything, but I'm not going to delay too much before I get started. Okay, cool. Awesome. All right, so the topic for today, if you weren't around, if you didn't catch us last week, we talked about diastasis recti, how you can check yourself at home for that. So today we're going to switch gears and talk about something much more intimate and much less well known at this point, much less discussed in public and just among moms. You know, diastasis is getting very the awareness has gotten much better over the past 5 to 10 years, and it's kind of a hot word in the fitness industry. Everyone's talking about it. But something that's also extremely common that no one is talking about is pelvic organ prolapse. Most women don't even know what that is. Unfortunately, most of us don't know it exists until we are told that we have it, and it can be a very scary, stressful thing for women when they find out that they have it, because they never knew it was a thing. They never knew it was an option or something that could happen after birth. So we're going to talk a little bit about what it is. If you've never heard of it before, you're not alone. We're just going to go through briefly what it is. There's different stages, and physical therapists and OBGYNs and urogynecologists, we kind of stage prolapses differently depending on, you know, what our particular profession is looking for. But I'm going to go through how physical therapists stage it with you and kind of what those different stages might mean for you in terms of your prognosis or how likely you are to improve with conservative care versus surgery. And then we will talk a little bit about that big scary S word, right? So one of the biggest things women have concerns about if they find out they have a prolapse is, do I need surgery? Because it's a scary surgery, it's a major surgery. There was a lot of fear out there because of a few years back, there was a huge thing with surgical repairs for prolapse not going well, and they were using a technique and a type of mesh that was there was a lot of bad press around it. So we'll talk a little bit about surgery and how do you know if you need surgery. And then I'm going to share with you the number one thing that I train my patients on that requires no internal assessment, no kegling, no nothing, that you can do immediately if you feel like you have the symptoms of this condition. You have no idea if you have it. This is something that you can do immediately when this Facebook Live is over to start to try to help your symptoms improve a little bit. So my number one tip that I give people, we'll go through that as well. So I'm going to try to rein myself in on time today. I went about 40 minutes on our last one. I'm going to try to keep it a little bit shorter than that so you guys can hold me accountable, but I don't have a clock, so so we'll see how it goes. And feel free to type questions in as we talk. I'm not great at looking at the comments and the questions during, but I will try to do that at the end if you guys type questions into the comments. And then of course, if you're watching this later, you can always feel free to private message me or email me or contact me in any form that's convenient for you if you have specific questions that you want answered about this. So let's dive right in. If you don't know what prolapse is, I did post an awesome graphic of the different stages. You can look at my feed if you want to check that out. I don't know how to screen share. I'm sorry, especially on my phone, but I would encourage you, you know, maybe after this, go back and kind of scroll through, or if you're on your computer and you have two windows, you can open up the posts or just Google search prolapse, pelvic organ prolapse. Essentially what it is it's a descent or a pressing down of one or more of your pelvic or abdominal organs into the vaginal walls. So you have our little anatomy lesson here, right? Here's my beautiful pelvic model. You have this bowl or this beautiful structure inside your pelvis that contains kind of all of your reproductive, your bladder, your uterus, and then your rectum is back in there. You guys can see it. Take these two guys out. You've got a rectum back there, and then you've got a uterus with a vaginal canal and a bladder. And the bladder is sitting kind of right next to the pubic bone, the uterus on top of that, and then the rectum back in the back. So you've got openings, right? You've got anus, vagina. We're talking about the female body here. Anus, vagina, and urethra up at the front. So kind of a little orientation for you to your anatomy. So when you have a pregnancy and you have growth of the uterus, obviously there's a lot more weight and pressure going down on the structures that are beneath the uterus. So that's one of the reasons that a pregnancy can contribute to a prolapse. It's essentially when you have this vaginal canal that's kind of sandwiched in between your rectum and your bladder, and then you've got intestines and all kinds of stuff above here. So when there's pressure, when there's an excess amount of pressure on those organs, and especially when you combine that with a big stretch or a muscle strain or a fascial strain or even a tear to these pelvic organs and ligaments down here, as with a vaginal birth, you can have some persistent descent of those organs pressing into that vaginal wall. So if you think you have a prolapse, or you see something, or you feel that things are pressing down into your vagina, it's not actually your bladder or your rectum that you're seeing or touching, okay? It is the walls of the vagina, the back wall and the front wall, which are being pressed down and out by the structures that are above or sandwiching them on either side. So that's essentially what a prolapse is, and we'll talk about the different types. But when those organs, any of those organs, or your intestines as well, can kind of prolapse down into the pelvic bowl closer to the openings, anything where things are kind of falling out of their designed original position and they're pressing down and outward towards the openings. So symptom wise, the most common symptoms, kind of the telltale red flag symptom, is feelings of pressure, bulging, like something is falling out. So if you literally feel like there's something in your vagina, something is falling out when you do a particular activity, or for a lot of women, it's just going to be at the end of the day. I see a lot of women who they're like, well, it doesn't happen with anything in particular, except just at the end of the day, I feel like just heavy, like something's there, right? Sometimes people will feel like they're sitting on a ball. So when you sit, you just feel like there's, again, something there, something that you're sitting on. Some women will feel, if you're running or doing some kind of impact, you'll feel like jostling or looseness, or like something's shifting around in your vagina. You might feel pressure or heaviness, or just feelings of heaviness is the best way I can describe it. And that can feel like lower abdominal heaviness. It can feel like rectal posterior pressure. You can feel heaviness or pressure in the low back. It can feel like groin pain, just groin discomfort. It can feel like it can present as incontinence. So particularly with bladder or urethral prolapses, there's usually always leakage that goes along with that. And sometimes it can be a cough, sneeze, laugh, stress incontinence, cough, sneeze, laugh. Sometimes it can be, with running, with impact, with lifting things, definitely with lifting things. Anything that either jostles the bladder or increases your intra-abdominal pressure, so the pressure that's above those organs, can cause leakage or an increase in those feelings of pressure, heaviness, looseness, and falling out. So those are kind of the big telltale symptoms. There are others. There are, discomfort with intercourse. There are definitely some other types of symptoms. Bowel dysfunction, difficulty with bowel movements, or sometimes difficulty releasing urine is a less common one. But really your telltale signs, if you're having feelings of pressure, vaginal heaviness, falling out like you're sitting on something, or you can actually see something coming out, those are all big red flags for prolapse, as well as stress urinary incontinence, and sometimes other types of incontinence as well. So the reasons for that, are pretty clear anatomically speaking. You have, so let's talk about different types. So you've got obviously different organs in there that can prolapse out. So the most common that we see is prolapse of the front wall of the vagina, which is where the bladder and the urethra sit, right? So there's different terminology. Not all professions and not all people agree on the terminology, but prolapse of the front wall of the vagina also can be known as cystocele or urethrocoele, where you've got the bladder or the urethra pressing down into the vaginal canal. So the front wall of the vagina is pressing down and out. So that's going to look like something that's close to your pubic bone, right, or underneath your urethra. Posterior wall of the vagina, when something is pressing down and out from the backside, would potentially be what we call a rectocele. So that's where your rectum is pressing down into the vaginal canal. There's also prolapse of the uterus, where you have uterine prolapse, where the uterus and the cervix are coming down into the vaginal canal. And then there is another very much less common type called enterocele, which is where the intestines are kind of coming down into that pelvic space. And there's also what's called vaginal vault prolapse, which wouldn't be an option unless you've had a hysterectomy. So unfortunately, you can get your uterus taken out and you can have what's left of the vaginal vault that will then prolapse down. And depending on what they've done in your surgery, there are some things that surgeons will do to try to prevent that from happening by tacking the vaginal vault up. We're not going to go into that much detail on surgery today, but you can, even if you've had a hysterectomy, if that vaginal vault has not been well enough secured to the structures up above, you could potentially have a prolapse of the vaginal vault where you see the walls of that vagina are coming down and out. So those are kind of the basics of the different types. We see, typically when you have prolapse of the bladder or the urethra, you're going to have more of those bladder type symptoms, the urgency, the stress incontinence, potentially some discomfort with urination, things like that. When you have a rectocele or a posterior wall prolapse, you're a lot more likely to have issues with bowel movements. Stool can get actually stuck in that rectal canal as it kind of is collapsing, and so there's kinks in it, right? Because it's kind of collapsing into the vaginal wall, so you might not have a nice straight pathway for your stool to evacuate, and so you can get constipated or difficulty with bowel movements where you can't quite get the stool out of the back passage because you've got a kink in it from the prolapse. And then what else do I say about that? So those are the kind of the different types. Most common for sure, especially in our postnatal population, is going to be the bladder and the urethra, less so the rectum prolapsing in, and then way back, less so is the uterine prolapse. There's also something called rectal prolapse, which is different, and that's where you've got rectal tissue coming out of the anus. We're not going to talk about that today. We're going to talk about more of the vaginal types. So stage-wise, the staging is just a way for us to gauge kind of the severity, right, of the prolapse. So how far are the organs coming down and pressing down? So there's 4 stages in the way that physical therapists and a lot of GYNs or OBs will classify it. And then there's a much more complicated scale called the POPQ, which we're not going to talk about. That's how urogynecologists usually, there's a lot more measurements. It's much more specific, and urogynecologists will use that to kind of determine, some different things that they would need to know related to surgery and treatment. So we're not going to talk too much about the POPQ, but if you go see a urogynecologist and you see it's like a square with like 9 boxes in it and they're letter labeled and different values, and that's essentially how they measure different points of the vaginal walls and how much descent there is in different areas. So it gives us a much more thorough look at what your prolapse is like, but it's not as easy to do that test. So usually it's urogyns that are doing that. For pelvic PTs, we're doing a much simpler 4-point scale. A grade, a stage 1 or a 2 is considered quite a mild prolapse, and a stage 1 to 2 has a very good prognosis from what limited research we have. Very good prognosis for recovery and just getting back to your normal life with conservative treatment, so physical therapy and effective pelvic floor training, etc. A stage 3 and a stage 4 have less of a good prognosis. A stage 4, so just to talk about a little bit how much descent that is. So a stage 0, no prolapse. If we were to, so the way that we look at this, right, we're doing an assessment of your vaginal walls. So we look at it vaginally, and we observe with bearing down. So when you put the most amount of pressure that you can down on your pelvic bowl, we have you hold your breath and bear down, right? As if you were pushing out a baby or pushing out a bowel movement. So we want to see under that high amount of pressure, how much descent do we see of the vaginal walls? So when you hold your breath and bear down, do we see no movement at all of the vaginal walls coming down? Do we see a tiny little bit of movement, would be a stage 1. Do we see a significant amount of movement, but it's not really coming to the entry, it's not coming outside at all, certainly, and it's not really getting too close to the vaginal opening. That would be like a stage 2. And do we see it coming to the vaginal opening and even a little bit outside. That's going to be a stage 3. And then a stage 4 is where you have it's coming completely outside. Your entire vaginal canal is retroverting outside of your body. Sounds terrible, right? It's not super fun to have. And that's much more common later in life. So one thing that we do know about prolapse is that it's chronic pressure over time is going to contribute to this condition. So people with chronic constipation, chronic coughing, poor lifting habits where you're breath holding and you're putting a lot of pressure down on the pelvic floor and on the organs repetitively, day in and day out for years and years and years and years. So many people will not be symptomatic until much later in life. So you might have a mild, prolapse after you have your babies when you're in your 20s. And then you don't feel too bad. Maybe you have a little bit of incontinence for 20, 30 years, but you think, oh, this is just normal. I had babies. This is just, it's not too bad. I'm just going to ignore it. It's not impeding me too much, right? And then all of a sudden you hit menopause and your hormones change and you have what we call vaginal atrophy, where the muscles are shrinking. You don't have as much estrogen, so you don't have as good bulk in your tissues surrounding the pelvic cavity and the pelvic bowl. And so now all of a sudden things are not well supported. You have hormonal changes. You have all kinds of things that contribute to your symptoms going up. And now all of a sudden you're very bothered by it. And so you go into your gynecologist to get assessed. And that's when they tell you, oh, you've got a prolapse. And at that point, it could potentially be more severe if you've had poor habits, right, for the last 20 to 30 years and you've been ignoring something. So, from a pelvic floor therapist perspective, we are very preventative mindset usually. We would rather have you come in, we find out, okay, you've got a mild prolapse. It's not really bothering you at this point. You're, 2 years postpartum. You're having not that much incontinence. It's not really bothersome to you, but we know that it's there and we don't want it to get worse. We don't want it to get to be a stage 3 or a stage 4 when you're 60 or 70 years old. So let's talk about some things that you can do throughout your lifespan, right, to minimize your risk of this condition becoming worse. And one of the hard things, like with diastasis, there's not a lot of great research on prolapse, so we don't have a lot of definitive statements that we can make about what's going to make it better, what's going to make it worse. So that's challenging. However, we do know that from what we do know about it and what we observe in research studies, we know that chronic poor pressure management, poor habits of bearing down, breath holding, coughing, a lot of intra-abdominal pressure that's not well controlled is very likely to contribute to a prolapse getting worse. So in terms of surgical management, in management from your physician, if you have a stage 1 or stage 2, they're not very likely to mention it to you unless you're asking about it. They very much make their management decisions based on, at least the ones that I've heard speak and from what I know of their training, they're very likely to make their decisions based on the amount of bother. So if a woman comes in and she's got a stage 1 or a stage 2, but it bothers her a lot, then the physician is going to offer her some different treatment management options, whether it's physical therapy, Kegel exercises, some other type of pelvic floor strengthening that they prefer, or potentially a pessary. And we're not going to talk about pessaries today because we just don't have time, but maybe we'll do another live and talk about pessaries. They can be a wonderful tool if you have a mild to moderate prolapse that needs a little bit of support. It's basically I call it a back brace for your vagina. So it's something that you insert. They're usually made of silicone and they just kind of hold, they give some support to the walls of the vagina to hold them up. They're not used very commonly in the US. Historically, it's been something that urogynes will prescribe for more like little old ladies, right? But in the UK, they use it very, very commonly at much younger ages. And I personally would love to see it become more common in the US a lot younger so that women can have some support. Again, from the preventative mindset, if we can support the vaginal walls while you have to lift your stroller and lift your baby and lift boxes at work and, do all these things that we lift at the gym, right? Do all these things that we want to do in our lives, that we need to do in our lives. If we can support the structures well, then maybe you don't end up with a stage 3 or a stage 4 when you're 60 or 70 years old. And again, we don't have research to say that that's definitively true, but it seems to make sense, right? So in any case, I feel the same way about, pelvic floor training. So a lot of physicians are still not referring if they see signs of a prolapse, but you're not reporting any symptoms or any bother, then they're not necessarily going to refer you to pelvic PT. It's kind of like a just let it lie mindset. It's not bothering you. We don't want to freak you out about it. So we're just going to kind of watch and wait and see what happens. And what I don't love about that approach is that we're not then doing anything proactively to teach you how to manage this so that it potentially doesn't get worse over time. So there's things that physical therapists, pelvic floor therapists are going to teach you that are going to help you to best support the situation in your pelvis with your day-to-day life, especially women who are more athletic and want to lift heavy, they want to run, they want to do impact sports, or they've got 5 kids and they're lifting and carrying them around all day. I would like for you to have tools to know how, I want to make sure you know how to turn on your pelvic floor, how to keep good mechanics, how to not hold your breath as a strategy for lifting, because many people do that. And even some, if you're more in the Olympic lifting world, there's a lot of training around breath holding as a strategy to stabilize your spine while you lift heavy. And the problem with that with prolapse is that you are cutting off, you're closing the glottis, so you're really increasing the intra-abdominal pressure, and then you've got a pelvic floor that potentially has never been rehabilitated and you don't know how to turn it on, and all of that pressure with your now 200-pound lift that you're doing is going down into that pelvic bowl and down into that prolapse. And if you're doing that 3 or 4 or 5 times a week, every week for 15 or 20 years, I'm concerned that that's going to be an issue, right? So there's different camps of pelvic floor physical therapists now, where we've got some who are very, very conservative, don't want you doing anything. And then we've got some who are like, well, we don't have any evidence to prove that you shouldn't do it, so let's do it. Let's do whatever you can or whatever you want, right? If you can do it, hopefully without symptoms, right? Not with symptoms. I tend to be more on the conservative side. I want to get you back to lifting. I definitely don't want you to have any symptoms, but if your prolapse is quite severe, I wouldn't necessarily feel comfortable telling you it's okay to go lift repetitively over 200 pounds just because you don't have symptoms now. Because there's a lot of women out there who didn't have symptoms for 20 to 30 years, but then all of a sudden they hit menopause and now our symptoms are really bad and it's a big problem, right? So again, I kind of have a more preventative mindset the way that I go about treatment. So I'm absolutely 100%, I feel yes. So if you've been told like you can't do anything because you have a prolapse, you can't lift, you can't run, you can't, do et cetera, that's not necessarily the case. So if you've been told that, it may be time to kind of go and reassess, go see someone who's maybe a little bit more not conservative. If there's things that you feel that you want to get back to and you're not having a lot of symptoms, then, let's go work with somebody who can potentially help you get back to those things, who can teach you the right way to do it and the right way to know, is it hurting you or helping you, right? And see how far you can get, because you don't know. Right? So definitely we want to see you stop leaking, right? So at the very least, we want to retrain and strengthen your pelvic floor and your pelvic fascia enough that you can control it, you're aware of it, you know how to turn it on. It is a many times proven fact that over 50%, somewhere around 50% of people who have been trained verbally or in written instructions how to do a pelvic floor contraction, so how to activate your pelvic floor effectively, don't do it right. So you might think you've been doing Kegels every day since you had your baby and you're not really doing them, or you're not really doing them in a way that's effective or helpful for your situation. There's also issues. You can have muscles that are tight, muscles that are not active. You can be turning on other things instead of your pelvic floor. So, game one is to how can we best support the vaginal walls by strengthening, building muscle bulk. If your prolapse is severe enough that that's not quite enough, can we add something like a pessary that's going to then give you just that little bit of support that's going to enable you to do what you want to do without bothersome symptoms, right? So without feeling laxity, heaviness, like something's falling out, without having incontinence, without having the low back pain and the pressure, right? So what can we do that's going to help you live your normal life, take good care of your internal pelvis, and not have a lot of bother, and then also not put yourself at high risk for having a worse scenario later on. So that's kind of the goals of conservative management. And I want to move now to this tip I was going to give you guys, because I've given this to people multiple times, and they come back for their second session and they're like, just doing that. Okay, so like they'll come in for their eval week 1, week 2. So 1 week is not enough time for you to have any increase in muscle bulk. Okay, so even if they did pelvic floor exercises every day for that week between session 1 and session 2, there's no way that they've built bulk or really any significant amount of strength in the pelvic floor in that time. Okay, so this is something that you can do with your mechanics and the way that you're moving that can really take the pressure off of a prolapse. Okay, so we're going to go back to a little bit of anatomy here. Number 1 rule also is don't breath hold, right? So start to notice when you feel your symptoms during the day, are you holding your breath? Because if you're holding your breath, again, you're cutting off, you're closing the system, and you're increasing the intra-abdominal pressure. If you're feeling a bulging, notice if you're breath holding. Be sure that you're breathing throughout the day, especially when you're lifting, pushing, pulling, activating things that are activating your core, right? Because that's going to put potentially some pressure downward. But again, we don't have a ton of time in a 30-minute Facebook Live, so I want to get to this tip that you guys can use. So a little bit of background here. So we talked about the pelvis, the anatomy, right? So with a neutral pelvis, you're in a neutral position. Your pelvis should be kind of stacked upright like this, and this is your front hip bone called your ASIS, and this is your pubic bone, okay? In a neutral pelvis, those 2 bones should be kind of in a vertical plane, and I'll stand up and show you this in a second. When your pelvis is oriented like this, or slightly what we call anterior tipped, forward tipped, you're gonna have your bladder resting a lot on top of your pubic bone, which is a bony structure, right? So this is a lot of solid structural support for your organs. Your uterus is then resting on top of that, and your rectum is kind of back in here, right? So when you have this nice neutral pelvis, not only are your organs resting more on bone, but your pelvic floor is more in a kind of an angled or a vertical orientation, versus if you are kind of bum tucking and slumped under, you are going to have now your organs and everything is resting really purely on muscles. And if you just had a vaginal birth where you tore through, or you stretched, maybe you pushed for a really long time and these things really got overloaded and stretched out, or we didn't even talk about tears, right? So if you had a vaginal tear, any kind of tear, but more so the grade 3 and grade 4 tears where they're getting up into this area, then you have healing tissue there, which now has all of the pressure on it, right? So if we can just bring you from a place where you're moving and sitting and standing and functioning here to where you're moving and sitting and standing and functioning here, even if it's not 100% of the time, even if it's like 75% of the time, but you're spending more time in this posture than in this posture, that can make your symptoms so much better, because you're removing the insult, right? I'm really big on removing the insult before you try to apply like more fixes, right? So the first thing you want to do is remove the thing that's aggravating. So if one of the things that's aggravating is that you are constantly tucking your bum and holding your breath, and you can just untuck your bum and breathe, then a lot of women will feel so much better. So I'm going to stand, now that you've kind of seen the anatomy, and hopefully that makes sense to everyone, I'm going to stand up and kind of show you how to workshop that on your own, and then we're going to hop off unless people have questions. Let me just see. No, I don't see any comments or questions. So perfect. So I'm going to stand up and just kind of show you how to find this on your own. Okay. So if we're talking about, here I am in quiet standing, right? So a lot of us, moms or not moms, have a lazy way of standing like this, okay? This kind of position where we've kind of rotated our bum under and slid our whole pelvis forward is allowing us to kind of hang on our ligaments of our hips and our lumbar spine. So if you're standing for a long time, this is a position, or you're holding a baby, right? This is a position that many of us will go into to get some stability, to let our muscles rest, especially let's say you're immediately postpartum and your core is all kind of tired and fatigued, and this is a really easy place for us to stand for long periods of time while we hold our kids or do our day-to-day activities, right? So kind of tucking and slumping, right? A lot of you are probably gonna be like, oh, that's the way I stand all the time, okay? So all I want you to do is I want you to think about untucking your butt and kind of standing, a little bit more actively, Okay, and we talked about finding the front hip bone and the pubic bone, right? So those pubic bone is way down low, so find those two bony prominences. And if we're in this bum tucked position and slid forward, your pubic bone is going to be out in front, okay? It's going to be out in front of your hip bone. So all I want you to do is try to bring those two bones in line and then feel, where is my weight going down through my feet? Is it all the way in my toes? Is it all the way in my heels? Or is it nicely kind of down through my whole foot? All right? So just a couple things I want you to do. Breathe. Check your pelvis. Okay, am I here or am I here? Or am I here? So untucking the booty a little bit. Visualize those organs kind of stacking on top of the pubic bone. Breathing, okay? And then and standing in that good position. And then when you move, so for example, if you go to pick up your 3 or 4-year-old or your 2-year-old or even your newborn, right? When you move, trying to, generally speaking, keep that nice untucked booty, right? So versus moving like this to pick things up, let's try moving like this to pick things up, okay? So again, something super simple, doesn't require you to know where your pelvic floor is or how to activate it. Just look at your pelvis. Are you tucked and slumped all day? And are you holding your breath? Untuck your booty, stand up tall, breathe. Okay, so hopefully that helps. That was a lot of information on prolapse. You can get more information on, I've past posts on Facebook and Instagram. You can also check out my website. I've got a couple blogs on there. There's other great resources, but if you have specific questions, if you have any of these types of symptoms, feel free to reach out to me and we can chat about the best option for you in terms of addressing your symptoms. I got one comment coming through here. I wear a pessary age 72. Can a rebounder be helpful for my pop? A rebounder, I'm actually not familiar with that term. Jenny, maybe shoot me an email. Wow, you stumped me. The first question. I'll look that up and find out what that is. I'm not familiar with that term. So, but great question. And I love to learn. So I will look that up and find out what that is. And then we can talk about it. If there's any other questions, go ahead and type them in there. And I'm going to wrap this up pretty soon. And again, the recording will be live. Oh, okay, so a trampoline like that you jump on. Okay, so you're wearing a pessary, a rebounder, so can jumping on a trampoline be helpful for your prolapse? I have never seen any research evidence that jumping on a trampoline would be helpful for a prolapse. But I can't definitively say that it wouldn't if it's something that is causing you to get better activation of your pelvic floor and to stimulate healing. And I think also I would have a lot of questions, right? Like, what stage is your prolapse? What else has been done for it? What other treatment modalities have you tried? And obviously in this scenario, online in a Facebook Live, I cannot medically diagnose or give medical advice to you, but there would be a lot of other questions around whether that would be a good thing for you or not a good thing for you, and especially surrounding, like, how are you doing it, right? And how do you feel when you're doing it? So that would be definitely an individual conversation that you'd want to have with a pelvic PT, because I wouldn't say definitively, absolutely contraindicated not, but there are a lot of factors in that. So hopefully that helps. Probably doesn't. Any other questions that people want to throw out really quickly, and then we'll jump off because I definitely blew past my 30-minute limit that I set for myself again. All right, you guys. Well, again, like I said, feel free to reach out with private message, with email, and if you have specific things you'd like to hear addressed in our next Facebook Live, definitely go ahead and shoot me those questions, any kind of pelvic women's health. You're welcome. Questions that you have, things that you want to hear talked about. And I do pelvic floor, but I do a lot of other stuff too. So if you want to hear about shoulders, if you want to hear about mommy thumb, if you want to hear about anything. All right, we'll talk about it all. All right, you guys, have a great Friday, have a great weekend, and we'll see you soon.